This week, we're turning to one of the most important building blocks of policy analysis, selecting criteria and assessing evidence. Criteria are the standards we use to compare policy alternatives, and they allow us to move from political rhetoric into structured, reasoned analysis. So over the next few slides, we'll unpack together what criteria are, why they matter, and how we operationalize them in public health policy. Our objectives today are threefold. First, you should understand the rationale for using criteria, why they're central to policy analysis. And second, while we'll review some of the most common evaluative criteria and their limitations. And third, we'll discuss how to move from abstract criteria to operational measures so that we can actually apply them in analysis. By the end, you'll be equipped not only to list criteria, but to critically assess how they're chosen and how they're used. Let's begin with the rationale and definitions. And before we get into specifics, we need to be clear about what we mean by the term criterion and criteria, and why criteria are indispensable in policy analysis. Simply put, a criterion is essentially a standard or principle by which something is judged or by which we make a decision. And it comes from the Greek word criterion, meaning a test or means of judging. In policy analysis, criteria help us answer the question, what does good policy look like? Without agreed criteria, there's no consistent way to compare options or justify one recommendation over another. So, why do we need criteria in the first place? Policy analysis is about using reason and evidence to choose the best policy from among alternatives, which we already know. But what does best mean? That's where criteria come in. As Munger puts it, criteria are the premises for analysis. They let us say what one alternative is better than another and why. Quaid expands this by saying, they are the standards that let us rank alternatives in order of preference based on their impacts. In practice, this means that criteria create the framework for evaluation. They allow us to weigh trade-offs and make explicit why we recommend one option over another, rather than relying on intuition or political instinct alone. Criteria are needed because policy analysis is about choosing the best option among alternatives, but there are two different kinds of analysis. First, descriptive analysis looks backwards, evaluating past or current policies. For example, how effective was a needle exchange program in reducing HIV transmission? And second, prospective analysis looks forward, estimating what would happen under a new policy. For instance, what would be the likely impact of expanding Medicaid eligibility in a state? In both cases, criteria guide us. They tell us what outcomes to measure and how to compare alternatives, and the analyst's tasks are to evaluate past performance and forecast potential results. To use criteria, we need to distinguish between these four related concepts. Goals are broad aspirations like cleaning up rivers, and objectives make goals concrete with time and population specified. For example, making a selection of the Chattahoochee River fishable within 5 years. Criteria are the evaluative dimensions we'll use to compare alternatives. For example, water quality, cost, legality, equity. Measures make criteria operational, and for instance, this can be dissolved oxygen levels at 5 milligrams per liter, serving as a threshold for fish survival. So we move from broad values to specific objectives to criteria, and finally to measurable indicators. This sequence helps us connect vision to evidence, and vice versa. Criteria are not neutral. They introduce the values and philosophy into the analysis. Munger reminds us that They're the premises for analyses, again, while Craig frames them as standards for ranking. However, Bartik and Pashnik make the key point that selecting criteria is the moment when values appear. Whether you emphasize efficiency, equity, or liberty reflects deeper philosophical commitments. That's why criteria selection is probably the most important step for linking technical analysis with real-world politics and values. For example, every major policy analysis framework includes a stage for selecting criteria, but they appear at slightly different points. Bardak and Pashnik, after constructing alternatives, you select criteria. Under the Kraft and Furlong framework, after defining the problem, you establish criteria before assessing alternatives. Patton-Sawicki and Clark is the same. Criteria come early before evaluation, whereas others like CV or Weiner highlight criteria for success or evaluation criteria as core steps. The key takeaway is that no matter which framework you use, criteria are central and they provide the lens through which alternatives are compared and judged. So it's important to establish criteria before you select or review policy alternatives. And why is this? Otherwise, you risk rationalizing your favorite option. And Patton and colleagues warn that criteria set after the fact make the analysis subjective. CV and co-authors even argue that setting criteria and choosing a program is like stacking the deck in favor of a predetermined solution. By clearly stating evaluation criteria in advance, we create fairness, transparency, and rigor in our analysis. We may revise criteria slightly as we go, but starting with them keeps the process objective. So now that we've defined what criteria are and when they should be used in the process, let's turn to the actual criteria themselves. This selection will introduce the most common evaluative criteria in policy analysis, things like effectiveness, efficiency, and equity, and more. But I'm getting ahead of myself. Whenever we think about policy, especially in public health, we need tools to evaluate whether a policy is good, fair, and workable. So these are the main criteria that we use in policy analysis. Though these are not exhaustive, first we may ask, will it work? Effectiveness is about whether a policy actually achieves its stated goals. For example, if the goal is to reduce smoking rates, does the policy help fewer people smoke? Second, efficiency is about resources. What does it cost and is it worth it? We're asking if society is getting the maximum benefit from the dollars spent. So think of efficiency through often a cost-benefit lens. Third, equity, which we have covered, looks at fairness. So policies might work overall, but still burden some groups more than others, and equity asks who pays and who benefits. For example, a sugar tax may reduce obesity, but could disproportionately affect low-income groups. Fourth, political feasibility asks, even if a policy is effective, efficient, and fair, will it move forward, and does it have political support? In a democracy, policymakers must consider the public interest and other officials. So feasibility is about what can realistically pass. So next, any policy must be legally sound. It can't violate the Constitution, laws, or individual rights. And keep in mind, legal rights evolve and can be ambiguous. Related to feasibility and legality is acceptability. Sometimes a policy isn't immediately popular, but with smart political strategies, such as reframing the issue or engaging new stakeholders, it may become viable. Even a good idea on paper can fail in practice, and so administrative robustness reminds us that a policy must be sturdy enough to survive real-world implementation challenges and still deliver satisfactory results. Finally, sustainability and technical feasibility. Can the policy outlast its original supporters and withstand political pressure over time? And is the necessary technology or know-how available and reliable? When we talk about equity, again, in public policy, we're really asking, is the distribution of costs, benefits, and risks fairly distributed across different population groups? So that's the foundation of equity in policy making. And one way to think about this is through horizontal versus vertical equity. Horizontal equity asks whether people in certain circumstances are treated the same. For example, do people in the same income group or with similar health risks pay similar costs or receive similar benefits? Vertical equity is different. It asks how people in unequal circumstances should be treated. Should resources be distributed differently to those who need more? For instance, should poorer communities receive more funding for healthcare access compared to wealthier communities? Then there's transitional equity, which is about fairness even when a change disrupts what people already have. For example, if a new policy removes subsidies or changes coverage, should people who lose out be compensated? So this is about managing fairness during transitions. And finally, intergenerational equity asks whether today's policies are fair to future generations. Are we improving living standards in a way that's sustainable, or are we passing along costs like debt, environmental change, environmental damage, or weakened health systems to those who come after us? Not all criteria are equally relevant in every analysis, so we need to cover about making choices, which criteria should be prioritized, and which ones might be dictated by a client or by the political environment. When we evaluate policies, we don't start from scratch. We start with the client. The raw material for evaluative criteria usually comes from the client's political and social environment. This is what we call issue rhetoric, the ordinary language of debate in client's context. For example, a health ministry may emphasize cost savings and efficiency, while a patient advocacy group may stress equity and access. Both are legitimate criteria, but they're framed differently depending on who the client is and who what the circumstances of the context are. So as analysts, we translate these concerns into measurable indicators. For example, effectiveness could mean a 20% reduction in new HIV infections over 5 years, whereas efficiency could mean a specific cost per life saved. Similarly, equity could be assessed by comparing treatment across income or gender groups, and it's important to remember that no policy option maximizes every criterion. The real task is figuring out which criteria matter most for the client and how to rank or balance them. There is always a trade-off. Now, context matters a great deal when applying these criteria. The same policy may succeed in one setting and fail in another. HIV provides many concrete illustrations. Take effectiveness, for example. We know that needle exchange programs reduce HIV transmission, but while they're effective in public health terms, some governments reject them on moral grounds. On efficiency, antiretroviral therapy, or ART, is expensive, but it's cost effective when we measure avoided hospitalizations and prolonged life expectancy. The policy problem is deciding whether scarce funds should go mainly to treatment, prevention, or structural interventions like housing. For equity, HIV exposes stark inequities. migrants, sex workers, men who have sex with men, all of these often lack access, and policymakers have to decide should resources prioritize the highest risk groups, or should the system aim for universal but thinner coverage? Then there's political feasibility. Some countries embrace harm reduction, whereas others outright ban it. For example, HIV education in schools may be routine in one place, but politically blocked in another due to cultural or religious values. So these examples show us that HIV is not just a health issue, but it's also a political and social one. Policy debates always involve multiple and competing criteria, and choices reflect the trade-offs that different contexts demand. Let's also remember that each criterion has its limitations. Effectiveness sounds straightforward, like does the program work, but often requires forecasts, and long-term outcomes may not be visible for many years. Efficiency can be powerful, but it risks narrowing the debate to costs and benefits while ignoring fairness or personal liberty. A program may be efficient on paper, but inequitable in practice. Equity involves value judgments. For example, is it more fair to prioritize the poorest or to treat everyone equally? These debates are subjective and often politically charged. Political feasibility depends on current coalitions and their preferences. What looks impossible today may become valuable tomorrow with strategic framing or shifting stakeholders. Finally, legality is never fixed. Rights evolve, and legal interpretations are often ambiguous. Sometimes it's worth pushing policies even if their legality is uncertain, knowing that courts may eventually decide. Because no criterion is perfect, analysts often use multiple indicators and sometimes assign weights to each indicator, and this challenge is navigating these trade-offs transparently and in line with your client's priorities. Finally, let's look at how to move from abstract criteria to practical operational measures, which means turning broad concepts like improved access or enhanced equity into indicators that we can actually measure. When moving from broad policy debates to analysis, we need to organize our criteria. Some criteria are values we want to maximize, like health gains, while others are things we want to minimize, like administrative burden. Some are absolute constraints, for instance, legality. It's most often useful to group criteria into benefits versus costs, and more importantly, criteria should be expressed both conceptually and operationally, meaning not just the idea, but a measurable indicator that allows us to compare across alternatives. Criteria become most useful when translated into metrics. For example, instead of saying minimize crime, let's specify a measurable goal. Let's reduce burglary by 10% in 6 months. This makes trade-offs clearer and provides a yardstick for comparison. Similarly, if your client values administrative ease, you can quantify that in staff hours. These translations make abstract values concrete and measurable so that we can judge policies on real-world outcomes. We also have to align goals, criteria, and metrics with time. Goals, again, are broad. For example, reduce HIV incidence, whereas objectives are sharper. Let's reduce new infections by 20% in 5 years. Criteria give us standards to judge whether we're making progress, and metrics make them measurable. But we need to be clear about time horizons. Short-term process measures like how many people were tested can give quick feedback, whereas mid-term measures might capture shifts in attitudes or behaviors, and even long-term outcomes reflect deeper changes in population health. A well-designed analysis specifies which outcomes can be realistically measured in each time frame. When we talk about criteria, we're talking about the standards we use to evaluate policy options. But not all criteria are equal. Some criteria are vague and may overlap, or even impossible to measure. That's where meta criteria come in. These are basically rules for judging the quality of our evaluative criteria. Our criteria should be about outcomes and not about specific strategies. For example, instead of saying the criterion is implement needle exchange programs, a better criterion is reduce HIV transmission by X amount. This way we're judging the result, not presupposing the method. Good criteria should be stated clearly enough that we can measure them. If we say improve access, what does that actually mean? Is it the percentage of people enrolled, the number of clinics, the waiting time? So you see that the clearer the criterion, the better the analysis. And where possible, we should allow criteria to be quantified. Not everything can be reduced to numbers, but the more we can compare across alternatives using quantified metrics, the stronger our evaluation will be. We should choose criteria that cover all major concerns raised by a problem, i.e. this should be complete criteria, and we risk overlooking important dimensions if we don't do so. Finally, criteria should be distinct from one another. If two criteria overlap, say efficiency and cost, we could end up double counting the same factor within our analysis, so it's important to keep clear boundaries so the criteria are mutually exclusive. So that's it for this lesson. Thank you for listening to the lecture this week. Next week we will turn to stakeholder analysis and health impact assessment.